And long story short, I'm going to say hi to Alex. Again, he's an anesthesiologist at the Brigham, and Andrew, he is the director of ultrasound point of care, at the Brigham. And everybody knows Dan, and I think some of you guys know me. I'm going to shut up.
Thanks, Ruin.
Thanks for that introduction. Yeah, we're really psyched to be here and kind of talk about what we have going on at Brigham, and we'll ask some questions. You know, when it comes down to it, we don't have all the answers either. I don't think anyone really has all the answers in terms of how to foster collaborations in an effective way, because it's different in each place. And that's what makes it so fun, but also kind of challenging. But I think it's ultimately worthwhile for sure. So this is something that you'll see at like lots of conferences, and they'll say, if you want to go fast, go alone, but if you want to go far, go together. And I don't think they really know that it's been quotes like Einstein, all these people, but I think it's just a cliche MBA phrase that gets tossed around, but it does ring true sometimes. And there are times when you want to be like Ricky Bobby and you just want to go fast and you just want to do it on your own, and like, you know, not have to worry about getting buy-in or consensus for everyone. But ultimately, doing it with a team is going better. So I'm coming at this from the OR perspective. I have background in, you know, enhanced recovery pathways, which again, it's surgeons, it's anesthesiologists, it's nursing, it's everyone coming together to build these pathways that improve patient care and bring a lot of these evidence-based elements to patients together. That's where my experience comes from research-wise.
And I got to give Alex some credit. About 18 months to 2 years ago now, Alex is the one who came up with this idea for higher level collaboration between emergency medicine, approaching us for a paper in doing so. So he's been at the leader of his field for a collaboration with emergency medicine, specifically for acute pain management. And so that's where this all comes down to.
But again, we're just starting off. There's a lot of stakeholders here in the game, and I think ultimately it's putting the patients in the center of everything that we do, and that's what ultimately gets most people on board. Is, hey, this is good for the patients, and the patients are doing well, and here I can show you that the patients are doing well. And if you have enough patients who do well, and you show people that, they'll get on board pretty quickly, even if they're, you know, hesitant at first. But especially for bringing nerve blocks safely and effectively there, you know, that's just the tip of the spear. The nerve block as a procedure is nice and good, but what we're really talking about is comprehensive pain management. The nerve block is a part of it, but and it's a valuable tool that we have in our arsenal. But how can we bring more effective pain management to patients in a way that, you know, is better than just let's just give them opioids and pray and whatever. Because our patients deserve it and our patients need for it. But there's a lot of different stakeholders here, as you all know, in this field. Of course, emergency medicine, anesthesiology, acute pain management, especially if they're going to the OR, surgery if they're going to the OR, but also the medicine primary team as people get more sick and more complex. It's important to do it. So this was a slide that we first used for earlier thing. We modified it for this because it's kind of the schema of how this makes sense, why doing blocks in the ED and intervening earlier makes sense, because you have your injury and then you have this period of time where there's an acute phase where you can come in and intervene. And normally when we think of acute pain management, we think of it in the OR, and we have our surgical friends, they're doing the big injury. It's not people getting injured at home, it's them with their scalpels or their hammers. Or I work in orthopedics, so it's a lot of hammers and drills and saws and all of that, but you can tell when they're getting injured. You know, it's a different schema when you're at home and you get injured and you come to the ED. But what's fascinating is that the responsibility for pain management changes, and who's responsible for actually treating the pain. Before the hospital, it's patients, but in this acute period of time in the OR or in the ED, it's us. And then afterwards, it goes to either the primary team, and then eventually it's back to the patient. But how can we be a part of this and be effective in this pain management? Because it is a shared responsibility, and we have to realize that we're playing an important part there, especially as we do treatments that go beyond when we're actually physically there and responsible for the patient. Like a nerve block can last 24 plus hours if you use, you know, adjuncts and you get a really good block in there. So, communication and multidisciplinary treatment is necessary, and collaboration is necessary, because comprehensive pain treatment is going to be multidisciplinary by nature. It can't just be a siloed, and that's how it's going to work in the future. So we have to be talking about it and thinking about it there. But it's hard. All this stuff's hard. Collaboration takes time. It takes ever. Like Andrew and I have been working for months to try and get something off the ground, and we're still kind of in that preliminary phase because it's tough. Our schedules conflict, and I don't know what it's like at your place or your shop, but scheduling is tough. It's tight. Like we are in a crisis of staffing, and we're still in a crisis of staffing, and making time for to have a multidisciplinary meeting is luxury profusion. It's not something that there's time in the budget for it, because you can't really bill for it. And if I'm not in the OR taking care of patients, I'm dead time to the people who are in charge. So a lot of it actually has to happen on the margins by people who are very motivated, which is hard because we're valued. Our time is valuable, and collaborating is hard because it makes you vulnerable. You do something you're really excited, and you don't want to be told no. That's hard to hear. But there are benefits. The way we staff our acute pain service is different than how the emergency medicine group is staffed, because we're only coming in kind of on banker's hours. We're 7 to 4-ish. That's when we have an attending in-house. There's someone on call all the time, and we have a resident on call all the time. But in terms of when we can actually, be performing nerve blocks, it's usually just during the operating hours. But that's not necessarily the case. And so there's this complementary staffing that can be helpful. And there's new techniques and shared techniques and different types of patients and different types of blocks and different types of approaches that can be we can definitely benefit from, and we can get a larger pool of patients. And ultimately it's all about better patient care, and it's bringing the cutting edge to the bedside. But also there's a different philosophies with pain. So the way I see a nerve block, it's a nice to have. You don't ever have to have a nerve block 100%. It's a nice thing, but if the risk is too high, then we'll just find another way. I have general anesthesia as a backup to get someone through a surgery, it's nice to have that as a backup. But it's different if it's on the acute pain service or in the emergency room, especially if we're trying to do procedures. And ultimately, what we found from this survey when we asked a bunch of anesthesiologists, acute pain anesthesiologists, is that people want to collaborate, and there's a need to collaborate, but we're not collaborating as much as we could be. So I think there are people in departments near you that want to do this because there's a perceived need that's not being met. We don't really know what the size of that need is, so we definitely need to have some more research in this space as well. So I feel like I'm talking right now.
That's
This is not
a question. Can I ask a question? So, I mean, again, I work at a very atypical center where there is a lot of collaboration. I hear from a lot of people around the country that the first blockade they have is orthopedics, which stops them immediately when they want to do blocks, and anesthesia. Less so anesthesia. And I think maybe at high-powered, big academic centers, there's this turf war. And then with orthopedics, it's irrational, made up. You're going to give infections. You're going to cause the leg to explode. You know what I'm talking about, the orthopedics that just doesn't fall in line.
The big concern with the orthopedics, and there's always a tension between anesthesia and orthopedics too, around nerve blocks as well. And the biggest tension actually is not necessarily infection or anything like that, but it's compartment syndrome. And compartment syndrome is what keeps orthopods up at night. It's kind of what's lurking underneath their bed, because that's why they get sued. And their perception is that if you do a nerve block, you get rid of their ability to monitor for compartment syndrome, even though when you look at the data, pain is not really a great, reliable way of doing that. But they're always going to use that as their first thing, like, oh, compartment syndrome, no, can't do it. And there's some cases where that's the case. There's a lot of cases where I don't do a nerve block in the OR because they're concerned about compartment syndrome, and it's taken a while to kind of get their trust and figure out, hey, that makes sense, that doesn't make sense. There are some, and reading about that, learning about that, and knowing which cases are high risk for compartment syndrome, so you can say like, hey, that's BS or that's not BS. Not necessarily the best way for collaborating, but the thing about the orthopedic surgeons is that they see the patients like each day, depending on what size hospital. If you're at a smaller community hospital, they're going to be rounding on their own patients and seeing their patients each day, and they aren't too keen on taking care of the patient. Like if you said like, oh, we can take care of their patient's pain better, they would be on board with that. They want better pain management also. But listening to their concerns, saying, hey, this certain type of patient, probably not. But sometimes they can be pretty concrete and say, oh, 100% yes, 100% no. But showing them early wins and listening to their concerns is a way forward to talking to them. With anesthesiologists, they tend to fall in line with the surgeons. So if you get the orthopedic surgeons on board, you can get anesthesiologists to get buy-in also, because as part of our, no one goes to a hospital for the anesthesiologist. No one says like, I'm coming to the Brigham and Women's Hospital because I want to see Dr. Alex Stone and I want him to take great care of me. Like, they don't. The orthopedic surgeons are the ones that bring in the patients. So if they say, hey, I want a nerve block for all my hip fracture patients, and I want it early and I want it before they come to the OR, the anesthesia group will collaborate and help facilitate that.
But I will say for the
yeah.
orthopedics at Brigham and Mass General specifically, it's been an education process. And I know, Arun, you've been able to get through this pretty easily at Highland, but it took very extensive literature. And I think it was an article about 2 years ago, and I can't remember which one, but they quote it all the time. And now they do not want their patients coming upstairs without a fasciitis block. So we have a policy in effect in the ED. And I know for those that we miss, because not all of our attendings are trained in nerve blocks or feel comfortable in it, Alex's team is the one blocking it upstairs in the next morning. And I know Alex already has protocols set up for rib fractures for very similar things as well with the surgical team. And so it's been a very big education and process. And this collaboration, I do feel like, will bring higher level education, not just to ED docs, but hopefully to these other groups as well.
And I can tell you, once the surgeons get on board, they're sometimes the biggest allies too. And once they see their patients are doing well, they can be the biggest advocates for expanding things, and people will move and shake. So it's worthwhile to like engage them.
How do I do it at a place that, again, I work in a very different place, right? I can do a lot of stuff that other places can't do. So I'm not, but I'm working somewhere where they're just, I want to hear from other people in the room who work at centers where people are stopping them from offering good pain control, in what you've done to kind of get around that, or what you've done, or you're still not doing blocks. I know Toby, when I gave a talk at Mayo years ago, they were not allowed to, and it took years and years of work to get them around that. How do they do that? Anybody on the call is having any difficulty with their consultants when it comes to doing femoral blocks or more esoteric blocks, or is it just all open season?
I mean, for us, at Mayo, they kind of came around as younger orthopedic surgeons came along that were trained in a different environment than the older ones. And as soon as we had the peng block, and had a little bit more argument with that it might be more motor sparing, then they were more okay with it. But it's usually always good to have discussion not at the bedside, to obviously have this more formalized. And we have a very good relationship with our trauma surgeons, and they were actually the one pushing it. So for ESP, and then we got anesthesia on board. So I think, not having to have this discussion with the resident who's not going to make any decisions that's against what they have been doing for decades, it's the way to go. You really have to engage them. You have to bring your data, and really have to kind of formalize the process, at least at a place like ours.
Buffalo. Sorry.
Go ahead.
At Buffalo, we had a couple of issues where the people coming in to see the patient for the first time from a surgical point of view is the residents. And the residents are afraid of anything new or unfamiliar because they haven't passed it by their attending, and they don't want to wake the attending up, because it's usually at night. And so I've been throwing my attendingness around as the power play there, saying like, hey, this is my patient. I believe this is the best, pathway for them, and this is what I'm going to do. I'll, send a message to your attending, letting them know this is what I'm doing, but I'm doing it. And I really haven't had pushback since those discussions. And it seems like other people in my department have also had near no pushback that I've heard about the past couple months.
We just took whatever the opposing department was, we found an ally and pitted them against one another. So we enlisted the help of our surgical colleagues. And there's nothing scarier than some of our surgeons. So some of the trauma guidelines actually do recommend now regional anesthesia for control of pain. So we sort of started on the download training some of the surgeons in rib blocks. So serratus blocks, which are super easy to teach actually, and erector spinae, got their buy-in for the procedure itself for pain control, and then told them, hey, wouldn't it be nice if we could have a similar protocol for our femur fractures, because we do get a lot of motorcycle accidents in our neighborhood too. And that kind of turned some of our ortho department around. This being said, we didn't really meet up with much resistance. Popliteal blocks for tibial plateau fractures, that's a whole different story. But overall, we actually got buy-in based on ease of procedures and good pain control, which we started off by just, the first blocks were actually, truth be told, for rib fractures and chest tubes. And then we moved on to lower extremity blocks too. So we kind of had to like gain traction somewhere, but then we just had other people yell at them. It works just as well.
I think Toby's point is really valid. I think it's this discussion has to happen away from the clinical department in front of the patient. This has to happen sitting down, having a cup of coffee, having a discussion with leaders in the department. Because at the bedside, there's no data involved, right? It's nonsensical. It's I want this, I want that, my attending wants this. Having a standard protocol written that's agreed upon by both departments really improves, I think, hospital care. I think even pushing it up the ladder to the C-suite, that's what I did at my hospital. They were really excited by this. I know it's different at different hospitals, but I think that conversation has to happen well before the patient comes in with a hip fracture.
Arun, the other thing I'd add that's worked really well for me at various places that I've worked is we all do a fair amount of faculty education amongst our own departments, and trying to pull your allies in when you're doing internal faculty education has been really helpful, because it kind of gives, if you start with one anesthesiologist from the acute pain service that gets to come in and kind of do their extra thing, they also can go around and realize that like our leaders in the field in our department aren't necessarily teaching voodoo. They're approaching with a very similar thing, and you can kind of build allies that way as well, which allows you to approach those higher level meetings with a bit more of a shared goal.
I think that
We did
makes a lot of
something
sense.
similar.
Yeah, I think
Sorry,
it
go
makes a lot of
ahead.
sense having a shared pathway and like having a protocol pathway, not doing it a la carte for every patient. One question I have for the group would be, is there a place or is there a mechanism for sharing these protocols or having cross-pollinations of these protocols so you don't have to make it up each time? And you can say like, oh, this is based on the rib fracture protocol at Mayo, or and then that also builds more credibility with it. Say, hey, they're doing it there, and every place is kind of wants to be doing it like Highland or wants to be doing it like here, and you can say, hey, they've been doing this there, and this is our protocol, and here's our inclusion, here's our exclusion criteria, and make it easy for people to get to yes, as opposed to say like, oh, I have to check with my attending and run it up and down. That's kind of like what they did with the EUAS programs, is they had the EUAS society do their whatever, but each place would be swapping protocols.
That's exactly why we started this. It was because we wanted this connection to grow, and so people were just cognitively attached to each other and thinking about blocks and then passing information back and forth, because there isn't really a great place where one person, I'm sure I was doing something and then somebody asked me for some help and I'd help them, and somebody, back and forth. And the goal was to really foster a group of people to all build together, right? It's train the trainers essentially. And so and you can see on the link, there are protocols that we're trying to disseminate, eventually publish. And I think that's the goal, right? Like publish a set of protocols, publish a set of discharge instructions, publish all this stuff, publish these policy statements, so that when people are coming in and be like, hey, I'm just going to make up a hospital, Florida University, and I want to start doing blocks because I see hip fractures. I have a lot of old patients. Where do I go to? And this should all be available for them to start. And that's the goal.
Perhaps a little side point, but is there any talk of creating somewhat of a 5-minute sono type educational session where you have your little, most of the time we just have the little cheat sheets, but I have a whole curriculum of videos that kind of breaks down every single block too. Are we starting a repository of these, or do we already have one?
It's a great idea. I don't think anybody's has gone and done that. It's a lot of work. If you want to build that, I'm sure we could use it, Dan, and have it in such a way that people can use it.
The Azra Best repository might be building that now. We saw that at their conference recently. And then, between the Highland site with their compendium of videos, plus you have then UC, not UC Davis. What's Jeff Gadsden? What's his place? Duke Anesthesia.
Duke. Yeah, they have
a great repository. Like, I very much am not in the game of reinventing to the quality that these guys have already made materials. So I usually just in my own curriculum put the links into whatever video I think is the best. Sometimes it's Duke, sometimes it's Highlands, sometimes it's 5-minute sono. But I think everyone should just make whatever their curriculum is. But each one of them has a pretty good bank that would do everything that someone would need.
I completely agree with you, Dan. I will say maybe it's more of a pivot to say, like, can we standardize the curriculum or put a base to it that every hospital is training their residents on? And because we got to figure out a way to make this scalable. We got like 15, 20 people on this call, and that's 15, 20 different hospitals, but there's way more residencies. And how do we get those folks up and running with something so standard and basic that they could use?
Yeah, no, I think you're totally right, Andrew. It's the scalable part. It's the hard part, right? Like, how do we get this to that tipping point of enough people doing it that it just becomes, the femoral nerve block and the serratus just become a part of residency training, and that takes us doing all this work at this point, and then eventually getting to a point where we add it into the standard protocol of residency graduation things that you need to do, like 5 intubations, you do 5 nerve blocks. When that happens, 10 years down the road, this just becomes the standard. I have residents at Highland who've graduated 12 years ago. They're like, oh, I didn't do any, XY block with you guys. I only learned to do the femoral. And so I think it's just the time that takes. And I think this is exactly what we're trying to do. I think that's the goal.
Has anyone had any experience in getting a procedure onto that list? Because I don't even know where to begin with cord.
Yeah, I don't know anybody. I think this would be a good idea to even, away from online to figure out who that person is or who the people are, and just send out that email. The same way that Andrew, when you and Joe were like, let's put something in to ACEP, and then emergency medicine to blocks. And I was like, that's a crazy idea. And I was ACEP president, and we just did it, right? Like, that was seriously like balls to the wall, excuse my vernacular, but it was like just making stuff up as we went. And that hopefully started the trend. And I think we have to do the same thing with the RRC or cord.
Actually, Arun, I wonder, next time I run into John Kendall, he might be a good person to talk to, given all of his experience with the AMIS and the focused practice designation. He might be a good person to start with and just see, because he's obviously been involved with both residency and ultrasound for a long time, so he might know.
Yeah,
it actually came up at cord this year, and they're not ready yet. So our residency director, he basically said, hey, I brought it to the table, and not many places have regional anesthesia as a part of their curriculum. So it's a little bit too early, but there are already talks of it. So this would be the, go ahead.
I'm sorry. No, this is the good time. You think this is the right time to start the process?
Yes, absolutely.
Yeah.
I think we just focus on fascial blocks. That is it. Get that in with the orthopedic data that's so strong right now.
But I think, Kat, building on your point from before too, like, if that's also now's also that time, if you can build that standard repository of like, if people that don't do a lot of regional anesthesia wanted to offer a 1 week elective at their own place, and then we've sort of built the repository of like, here's your standard approach to learning this so that you can deploy it quickly. That may be why, like, condensing some of that stuff so that you've kind of got an asynchronous curriculum already built, I guess.
I have
offered.
one.
Yeah. I mean, I think all of us
Uh,
individually have created
yeah.
our own at our
Yeah.
site, but like making a national, like a nationally agreed upon one might have more weight than each of our sort of like, hey, this is how we do it at Denver Health and University of Colorado. This is how we do it at Highland, whatever. It's almost like if we become the collective and say, this is what we think based on a group of 20 experts is the best way to learn it. Like, not to say that any of ours is, or yours is not effective,
Yeah.
but it, might add the extra weight that we need.
I think that would be a great paper.
No, go for it.
I'll
Sorry.
ask you, Andrew and Alex, one question, because it's something that I think is really a pivotal question when it comes to having other departments accept what we're doing. And that to me is, and I'm going to use the wrong term of the wind-up phenomenon, and the idea that, well, why does Arun need to do a block in the ED? Why doesn't he just wait till the patient gets admitted to the hospital and the anesthesiologist comes down? Why can't I wait? And for me, the answer from the reasonable amount of literature that I've read is the fact that treating pain acutely, and it doesn't have to be to zero, but at least addressing the severe pain up front can reduce downstream increased pain. And so, but by me addressing pain, both with a multimodal approach with a block and intravenous medications up front, I can help the downstream process, not even recovery point, like as in walking, but just pain downstream. Have you heard this, Alex? Is this something you buy?
So what you're referencing the connection between acute and chronic pain, and kind of that transition between acute and chronic pain. And it's one of like the holy grails in anesthesia. And there are some papers that indicate to it a little bit, and it's kind of like belies the whole field of acute pain management. It's like, why are we doing these nerve blocks when they wear off in 2 days? And what's the point? Like, so there's a lot of people thinking about it. There's nothing like that's like 100% like, yes, 100%. Like we can say that if they, if acute pain is treated, effectively, then there'll be no risk of chronic pain, because rebound pain is a real thing. And rebound pain is something that we see a lot. And it's what happens when the nerve block wears off. And do you actually put patients worse off afterwards if you don't put them on an effective pain management plan? So it's a very complex question. There's actually going to be a RAPM this year. This September is going to have a whole issue kind of on that phenomenon, and they're going to have basic science and also clinical science, and it should be interesting. It'll come out in September.
Because that goes to the core of the question, right? That goes to the core of what we're here for.
Does stopping acute pain prevent chronic pain? Because it's nice, and I think there's an argument to be said that stopping acute pain is preventing suffering, and it's worthwhile in its own right to stop acute pain if you have the means of doing it. But that connection to short-term and long-term outcomes, there's some stuff indicating to it, but I don't think it's 100% like one-to-one if you do it there. But it belies the whole acute pain management movement and acute pain regional anesthesia society. It's one of the big underpinnings, but I can't say 100% definitively that there's like smoking gun evidence that you do this and they'll prevent it there. There is a wind-up phenomenon, but theory, but I don't know.
Alex, do you think there's a difference between rebound pain when it comes to patients that went under elective operative versus like actually suffered an injury, got in a block, and then kind of were maybe a little bit more cautious of staying on top of their pain? Or do you think it's all the same?
I think that's a great question. So, the way I see it is when I do rescue blocks in the PACU, patients are a lot less likely to have rebound pain. So I think a lot of it is expectation setting, and it's if they've had pain before and they see like, oh, this is the block, and then I know what it's going to be like. I think that is a protective thing, that preventing rebound pain. But it's a fascinating question, because no one's actually looked at rebound pain in people who get blocks after trauma or after, you know, in the ED population. It's typically after dense surgical nerve blocks that they have rebound pain, but maybe it doesn't happen after blocks in the ED. We don't know.
No, for the group, it's just Alex published a piece on this recently. That's maybe a year ago, right, Alex? And the concept of rebound pain, you can talk about it more. But the point, whenever I do blocks in the ED, I always put people on non-PRN pain medication, because what my fear always is that I block somebody and I discharge them with whatever, and then they assume that there's no pain, so I don't need any medications. So I tell them to take the same dosing that they would if that pain was there on a non-PRN process for 24 to 48 hours. I don't know if that's too long or too short, because I know that when that numbness goes away, they're going to have severe pain and then come back to the ED. So it'll be an interesting thing to study.
Yeah, it would be, especially to say like, hey, if we're doing this and we're sending people home after nerve blocks, what are we doing to make sure they're not coming back? And again, it gets into that continuum of like, all right, who's responsible for treating the pain? In the ED, it's you all, but then once they leave, it's the patients or their primary care doctors prescribing, and they're, you know, taking the medicines. So, you know, rebound pain, it's a big question in anesthesia. You know, a lot of the patients, I know that Andrew took care of a patient who had a surgical procedure and came back for another nerve block after the nerve block wore off, and was treating rebound pain in the ED. And it's seen, if you look at the data, it's not an insignificant percent. I think it's around between 1% and 5% patients have rebound pain, and a lot of them come to the ED for treatment.
I do think it's the staying on top of your pain, like Arun says, like with Tylenol, ibuprofen around the clock. And if you weren't in pain before you went to the hospital, you got the nerve block and you're very little pain afterwards. My gut is saying you're not staying on top of it because you're just not used to it yet. But that's just my gut feeling.
Yeah, but it's interesting. It falls in the realm of patient education, giving them good discharge instructions, and that's another area where I think collaborations can be very helpful.
To get back to the kind of the topic we were on, these are the things we've been doing at Brigham specifically, and where we foresee this going. Right now, the problem is that only a group of us in the ED are block on a regular basis. We have an acute pain service is awesome, but they do the blocks upstairs on the floor. Currently, there's a rib fracture pathway. There's a hip fracture pathway for the ED, meaning that all patients with 3 or more rib fractures who are in pain get an nerve block either by us when we're available in the ED or someone's there, or by anesthesia upstairs. Regardless, they all go to the ICU for airway monitoring, and that's just a rule at Brigham that I don't really understand, but that is what it is. And where we're going is kind of having more of a collaborative approach to this, where we share these responsibilities and just focus on these 2 types of blocks, have joint education around them, have joint QA and systematic review. That's kind of where we're thinking as a group here, and think of kind of the high yield blocks that we could potentially go after together. To Alex's point, there's always tough with time, and that's been the biggest thing so far, because we thought about doing this 18 months ago, is that there's been an anesthesia shortage as well, trying to get some help at night and in the evenings for those that not sure how to do it. But love to hear what you guys are doing with collaborations with acute pain services, whatever it may be. This is just stuff that we've been thinking about here at Brigham.
Yeah, and just thinking about how you kind of take that first step, how do you initiate a collaboration, and like how do you set forth a protocol and demonstrate a need? Because everyone here is here because they're enthusiastic, but you have to be persuasive and convince, you know, anesthesia or surgery or whoever the other stakeholders are that, hey, there's a need here. And what do you do to do that aside from just show them the data? Which is, again,
for one point that I think has been useful in the past is I put other services on my papers. So I let them be involved in the research process. For them, it's a huge thing. They also then get excited about the pathway, that we're going to collect data on patients, inpatient, however you guys want to build it based on your collaborations. I think it's always good if you're at an academic center to have these multi-specialty collaborations. I think it brings parties together and allows a lot more growth when you're looking at, questions together.
Yeah, I think research is a powerful tool that should be used for not just like initiating collaboration, but sustaining it too. Because if you're collecting the data anyways, there's so many journals out there and there's so much of a need to actually have this out there. It's pretty easy to, instead of just saying, all right, we're just going to publish with the, X specialty, to say, hey, like, let's bring in as many people involved and get them involved in doing meaningful work. But if we're collecting the data anyways, and it's everyone's patients, it's a great way of getting buy-in. And that's another trick from like kind of the enhanced recovery pathways. It's a lot of those publications have surgeons, have anesthesiologists, and they're published in both sets of literature. It's not just the anesthesia literature. It's not just the surgery literature. It's kind of this perioperative space.
We've also invited other services to our training sessions. So we have a once-a-month sim lab for regional. So, and we divvy it up just by, okay, 1 month we're going to do hips, another month we're going to do ribs. And we invite any attendings or fellows from other services, such as the SICU fellow comes down, some of their attendings come in smatterings, and they come down and sit for the sessions. That seems to go over pretty well, and they're much more eager to stab things.
People love stabbing stuff. It's good. And
right?
it's
a great activity.
It's dirty. People love getting their needles dirty and getting things going. But that's awesome. Have you gotten like anesthesiologists involved to like help you? Because it's something where anesthesiologists, a lot of them feel like they know nerve blocks. Some of them don't. A lot of them do. But again, having the ICU fellow come and having people come, because it's this powerful skill set that people want to learn how to do and do well.
Oh, they love it. So the anesthesia department now wants us to run their sim labs, which I find very special. So it's actually gone over really well. We also have trauma has now also volunteered their cadavers because they have an asset course that comes once a month. So in terms of, surgeons just basically take their cadaver and play jump rope when intestines or whatever on earth they do. So us just doing a little injection on the side really does not impede their experience. So we use the cadavers before it's used for the asset course, which is a trauma sim training course. So we've actually benefited from this too.
That's awesome. Yeah, I remember in fellowship they had cadavers because it was orthopedic. It was an orthopedic hospital, and they had all bits of people, and they were like, "Oh, we got a nice shipment of arms. You guys want to do some art?" This kind of gross and cool, but very cool and very fascinating because you can see the anatomy in a whole different way. And they were happy to have us kind of come in and do their thing, and they have the resources anyways. But especially where I feel like, as a specialty, emergency medicine is a leader in simulation, and that they're kind of you guys are on the cutting edge for that, and like way ahead of other places. That's a natural fit where you can take your expertise and plug in some other like expertise or standards or whatever, and it can be a really nice area where everyone can benefit from. Because again, our emergency department, they run our simulation center here, so we have a liaison from our department there. But it's the people who are truly like sim center trained that lives in emergency medicine.
Here's a question for Arun and the groups that are doing mirror blocks way more regularly probably than a lot of us. Us at Brigham have hit this kind of wall. We went from pretty much very little to this moderate amount. And this collaboration is my hope that can bring it to the next level. What have you guys done to kind of bring it up to that next level where you're getting more blocks regularly per day than just this small group that's very interested? Because that's where our wall has kind of hit now.
Yeah, I mean, I think it's a little bit of time and a little bit of work. I will tell you that ease of use is very important. User-based design, all the fancy buzzwords you want to use, essentially making the blocks easy. right? So I think of it on the front level and the back level, having the supplies really available. It's so simple that it's not a huge task. Having documentation that's so easy that it's a click of a button. I mean, you know, you could, it sounds like a bad Apple ad, right? And so to make all the annoyances that your residents, and it's going to be internal, your faculty is like, well, it's a real pain in the butt to get bupivacaine. Okay, we get stocked. It's a real pain in the butt. Our needles, okay, fine. Our systems are not charged. Like all those little things, which I spend way too much time thinking about, because that's kind of I enjoy kind of fixing these problems. It has to be easy. And then I think really getting your colleagues, for us, it's trauma. Like our trauma surgeons, and it will come up to you. I'm going to go in and scan at 1. They're gonna be like, there's a block in 12, there's a block in 16. This guy has a rib fracture, and this guy has a humerus fracture. They literally are asking me to do blocks. And that just comes from a cultural change and over time. And I think Toby is correct, right? Not to sound morbid, but some of these people have to die off before the new young doctors come on and we're like, obviously you have rib fractures, I'm going to block you. So I think that there is I wish I could rush it. I think rushing it is what we are as emergency physicians. We're terrible. We all do blocks and ask that pain's better. You kind of have to let it stir a little bit and slowly, I think you will get another lip, because I guarantee all your interns want to do blocks. Everyone, I guarantee, wants to do blocks. Is that correct? Everyone, right? So
Correct.
that is just the delta, right? Because every one of those interns, when I came to Highland, the 4s were like, we don't do blocks. Blocks are stupid. Why do you do a block? And it was that same mentality at Highland. And then now every intern is just like, that's all they want to do. They want to do blocks. And so I think it's this slow grind that you have to go through. I think what you've done, which has been fantastic, I think in 3 years, you will see the payoff. It's hard as the ER physician to do that, but it's that slow kind of delta. And I know it's frustrating to me because I want everything done today. We're so impatient as ER physicians. It is the great thing about us, and also something that really hurts us at the end. But I think recognize that you're building, you're planting the seeds for it to grow in 2 or 3 years.
We're in that phase where 80% of residents want to do them, to the point of where they'll do them and then get in trouble, and I hear about it because they did it
That's
without
all right.
attending supervision.
That's
And
all
I
right.
just keep saying, kind of, I have to tell you no, but maybe
right.
you can just do it, and we'll
That's
just play it off as it was okay.
That's right. This is the echo. This is the echo that the attendee doesn't know how to do echoes, and the resident does it. I think you kind of have to skirt on this line of like, you have to show your attendings, but I know you're not, because they have no idea what you're looking at. I think it just takes the work up front, building it easy, getting people excited. Like if you ever want to shame an attending, train your intern and your second year to be better. And those people, when they graduate, will crush it, right? That's the population that's going to change the world. And it's terrible to say, but they're the ones who are going to, get me out of a job and be better.
I was going to say, I think that really getting your department, your multidisciplinary kind of collaboration to work, because I mean, I was a resident at Highland when I was a resident like 5-6 years ago. I remember we would get almost in trouble for doing a serratus by the trauma team. It was very much a cultural change. And I think just really having the impact that the team sees. I mean, it's so surprising that just thinking just 5 years from when we were getting in trouble by the trauma attending, or like, what are you doing? Why are you touching my patient? To Arun's right, you come on shift and there's literally a list and you're like, I can't just do blocks all like scanning shift. I need to like actually teach the resident and the intern how to do other stuff. But it's such a big cultural change that took, I guess, 5 to 6 years to happen. But I guess it will happen when they start to see the benefits, right? So I think people believe once you actually see the benefit.
And I think that's the importance of collecting the data, so you can show them the benefit, saying, hey, we reduced this by X amount. And part of collecting the data too is, we said that it costs time and it costs money to foster collaborations and put these systems in place. Are you guys able to bill for blocks yet? Like, is there like a infrastructure for doing that? And like, can you show that, hey, this is an additional revenue stream that we're generating by doing it, just to show like ROI for the the people with the money persons?
We bill, Alex, but it's not as much as you probably think it is. what we get actually back.
Oh no, I know how much we bill on the floors. It's a peanuts. It's like a maybe like $50 or something like that. It's actually for the amount of liability that you're taking by doing it. When it's not a significant amount of liability, you're doing an invasive procedure. You're injecting, we call it just local, but it's cardiotoxic nerve poison. The branding on local anesthesia is great.
You can never say that out loud, Alex. Never say that out loud to a bunch of doctors, because you cannot say that. I never ever.
I tell all my residents, and I tell all my fellows that this is not local anesthesia. This is cardiotoxic nerve poison. It's magic nerve poison that wears off eventually. But if you think of it as I'm injecting cardiotoxic nerve poison in this patient, they'll aspirate. They'll be sure not to do an intravascular injection. And if you treat it as such, you won't have any problems with last.
They'll tell my chairperson, Arun just called this cardiotoxic nerve poison. And I'll get a phone call. Be like, what are you telling the interns?
Big bottle. I want 30 cc's of cardiotoxic nerve poison. But no, if you think of it like that, you'll use the absolute minimum amount that you need to do your task, and you'll be better off for it. But that's the mindset I always have when I'm doing the blocks. Like, I can only break this patient and make this patient worse. And so first, do no harm. And if you're going to use the cardiotoxic nerve poison, just use the right amount.
Hey guys,
Again,
since we're kind of coming up on the end here. A couple people are going to have to drop off pretty soon. What would you guys like to see next from this group in terms of action points from the policies and politics side of things? What do you want the group to try and work on or collaborate to create or identify? Just let me know if there's anything in terms of needs.
I think there's two things. I think it's a standardization of curriculum aimed at fascial blocks that can be used by everyone across the country. And then two, the slow process, which will take 3 to 5 years of getting fascial blocks on that procedure list. Because ultimately that will expedite everything that we're trying to do.
I mean, this may be just maybe that's the Kendall conversation, but having somebody who writes the requirements for residents in emergency medicine, who is part of that working group, and to get their ear and be like, I think a femoral nerve block is part of that process. If we can just get one block on there, then it changes the game, because then it allows all of us to really hang our hat on that people are going to be trained nationally before they graduate from residency. I think it's a lofty goal, which may not happen, but at least it's something that if somebody and I'm sure I can investigate. I just don't have the bandwidth right now. If somebody knows somebody in that position, we could even just have a conversation with. This is with me calling up Chris Kang, the president of ACEP, and be like, hey, Chris. He's like, who are you? I'm like, I want to talk to you about doing blocks. So I think even that conversation will be useful.
You sound like a Jehovah's Witness. Can I talk about blocks?
I wonder if it'd be good if they actually came on here and actually talked about it.
The ACGME has a current recommendation for new ER programs to add 10 regional ultrasound guided regional nerve blocks or regional anesthesia techniques. That's currently, I believe, under review and open for public comment. And I think that sounds like what you're aiming for. Do you want it to be specifically fascial, or do you want to leave it open? I would like to leave it open.
And maybe this is a conversation offline, but I think that we should, somebody missing a small working group that wants to push that forward, who has more political. I mean, I know everyone in this group is like me, like to stick needles in people and do procedures. That's why we're all in this group. But there's got to be somebody we can enlist who understands the political underpinnings of this and figures out how to roll that through, rather than how we did last time, which was just put our head down and bang against the wall a bunch of times. I think it'd be really smart to get that. I don't know the answer to that. It's above my.
I'll look into it, but I'll see if I'll put a ping out to see who's interested.
But if they say like, hey, this is going to be a thing that's restricted because there's only so few places that do nerve blocks effectively, because they want to make sure that it's inclusive to all programs, you could counter that with the argument saying like, hey, you could always have them rotate through anesthesia. They are rotating through anesthesia anyways for airway sometimes, and it's another way of promoting collaboration and saying like, hey, like if that's a standard, then you're going to have more, cross training and cross pollination. So
Alex,
you know,
how many
most hospitals.
blocks is it in anesthesia required to
For
graduate?
for the residents, it's 40.
40. Yeah.
But they're taking a look at that too, because it was, you know, I think that was from before the time of ultrasound actually, and then that was when you had to do it by feel. So it's like 40 epidurals, like 40 spinals, and 40 peripheral nerve blocks. But now that ultrasound's there and it's become more ubiquitous, I don't know what they're going to do, but
Is it
viewed
40
like,
of any block?
40 of any block.
Okay. Okay.
And most places get it. It was something. It's harder for some smaller programs, but most places, because they do so many blocks in surgery centers, like I spend a day a week at a surgery center and we're just blocking everyone because you got to get them out, and it's a consistent anesthetic plan where the analgesia is excellent, and if they're vomiting, they have to be overnight, and you can't be overnight. So because it's in the mall. It's not in the mall. It's at Gillette Stadium, but that's pretty much a mall.
It's in a mall.
It's in the mall next to Gillette Stadium. Then they have some
Ship
ORs
them
there,
off
but-
to Panera.
yeah, well, yeah, they go to get their burritos afterwards. The rise of, honestly, the rise of ambulatory anesthesia has catalyzed a lot of this, and a lot of it is driven by the fact that you can do more things under a block, and you can get patients out consistently. And are we kicking the can? Are they in a lot more pain at home? Maybe, but more and more folks are doing day surgery because they'd rather be in pain at home than in pain at the hospital. And managing it their way. So in any case, yeah, it's a long answer to a short question. It's 40 blocks for our residents, and then for fellowship it's different.
I don't know how you guys feel, but I almost feel like for EM, would be better to be just fascia iliaca and own it, and then expand, because that way it becomes a much simplified process for community sites that don't have like an ultrasound director or something like that to get it going.
Yeah, train easy and make them want to do more. Like I can do 5 of these blocks, and then you make them do 5 more rather than asking them for such a high level. It's like making them do 40 TEs for the credential. There's like, it's never going to happen. They don't even start. So yeah, I agree.
It's interesting though, because I think fascia iliaca, even though I think that it definitely has the most literature to support it, especially when you look at other specialties, like in our shop, we have one specialist kind of like blocks that prevents us from doing that every time. So our fascia iliacas are actually pretty low on our list. What we do a lot of is brachial plexus, upper extremity, like things that we're discharging home. And that's actually super useful. And I feel like my colleagues who don't even really do a lot of ultrasound really want to jump in on that, understanding how to do shoulder reductions with a brachial plexus block. Like that just seems to get less pushback up front. So it's interesting because I think that fascia iliaca should be the one that should be able to be pushed through universally, but it's just not the case always,
Yeah, and I've actually started doing femorals and lateral femoral. I've been targeting the lateral femoral cutaneous like individually, and I do femoral and the lateral femoral cutaneous for my hip fractures now, as opposed to doing the fascia iliaca. So, the literature is always changing. It's tough to say like, hey, we do like one block in there, but sometimes I'll do it like a superinguinal fascia iliaca also. But it's fascia iliaca can be I see a lot of, because I review the scans from the hip fracture patients that I'm doing in the ED that get the block in the ED, because I'll do the case, and when they come to the OR, sometimes it's said it's a fascia iliaca, but I see the femoral nerve and it's a femoral nerve block. So it's hard. I mean, those patients aren't getting up and walking before surgery, so a little bit of weakness doesn't necessarily hurt it. But again, we don't have the data.
I think if we're going to be talking about like ACGME recommendations for procedures, it's probably better to leave it open and say like, okay, we have this recommendation that in order to graduate, you have to do 10 regional nerve procedures under ultrasound guidance. That doesn't include like digital blocks and non-ultrasound guided blocks. To like zone in on fascia iliaca in the ACGME like writing, I think is setting us up for failure. Is because if the literature changes, that's going to be a problem. I don't think it's justice to regional anesthesia that we are performing. And when I'm developing a SOP for the VA, and they keep telling me as general as you can make this, because people run into problems with specific language. And so I'm kind of putting in that same bucket. Does that sound like a good idea? Just leave it general?
It's
think
probably
if-
better. It just leaves it up to curriculum design to make it super broad, which can then lend its difficulty into making it scalable. That's my only concern with it. But you're right that if the literature changes, we're screwed.
I think it might get easier buy-in because some shops always have that one crazy person that stabs everything in sight, and that person might not know every single block, right? So some people might be comfortable with hips. I mean, we do all 3 hips at our shop, depending on how big the 3 hip blocks, but some people are just really not comfortable with interscaling. So leaving it vague might actually get buy-in to just get them poking patients. And once you learn 1 or 2 blocks, I mean, let's be honest, the newer blocks we just learn on YouTube, right? Tell me I'm wrong.
Totally
No,
right.
I think the biggest thing, and the
100%.
biggest educational stuff, like learning a nerve block, learning the anatomy, yeah, you can learn it on YouTube. The biggest thing for me is making sure that they're getting monitored in a standard way, that they know about last, that they're not like, that they know how to rescue last, that they know how to aspirate to make sure it's not an intravascular injection, that they know kind of, hey, when I shouldn't block, as opposed to like when this is not a good idea or when there's neuro deficits.
Yeah.
And that's the more valuable lesson than can you find the plane? Like, sure, I don't care if a block doesn't work, 9 times out of 10, because if you're causing like LAS, or if you're causing like a monster complication or a neuropathy, like whatever, like that's like way worse and that can kill a whole program. But
Yeah.
knowing the process for how to do a block and how to monitor a block safely is way more important than the specific, like, all right, you can identify this anatomy, or knowing like, when there's a paresthesia, don't inject into the paresthesia, like things, basic things like that you can apply broadly. I think, and having a program where, hey, we're doing blocks at a high standard in a safe way, or like don't inject when you don't see your needle tip, that kind of stuff. It goes beyond just knowing a specific anatomy. I don't know. That's my bias. That's my 2 cents.
No,
And
I
I don't-
agree completely. I think that's what we should focus on. Because
Yeah,
I feel like
the
all these
basics
routes
are-
we can kind of build that out, and I think like there's a role for like workshops and standardization of protocols and whatnot. But I think like that's what I worry more about. I think it's easy to teach the block. I worry more about people doing their block appropriately when I'm not around. Like selecting the wrong patient, doing a complication. So I think focusing on standardizing, the consent is more important.
Yeah, how to talk to a patient about how to consent it, because like if you don't do informed consent, that holds you up to a whole bunch of liability, and it's especially hard for patients who are in pain. Might be like just knowing how to consent a patient properly to protect yourself and your the person who's signing your chart, like from the trainees, like if they're doing their consent, you have to make sure that they're doing it in a truly comprehensive way, because it is a bunch of you kind of own that nerve and you own that limb once you block it.
Yeah.
If there's a complication.
Yeah, but I think there's also like the chicken and the egg. Like we have to start teaching it in order to get good at the safety.
For
you
sure.
know, so for
It
both.
takes reps.
Yeah, so I think we're gonna end it there. We lost a lot of the group. I'm gonna stop the recording.